Good evening, everybody, and it's pleasure to have you all today. One more MDM. Good to see you, Professor Wells. Rajan sir is joining from Delhi, and he looks okay. Good to see you, sir, and Bhavin sir.
Morning.
We have got 6 cases. Sharda will be joining, but actually we do not have any pathology, so pathology expert is not needed as such. Mithun will be joining in a while, and I will start with the first case. First case is by Dr. Kaushik Mutturaja. His PG Gokul will be presenting, and I will share the screen. Sorry. Yeah, Gokul, you can go ahead. Yeah.
Yes, ma'am. Good evening to all. So, I will be talking about the patient who came to our hospital. So, this is regarding a patient, 53 years old female from Chennai. She came with complaints of shortness of breath for the past 1 year, which was initially MMRC 1, which progressed to MMRC grade 2. And she came to our hospital for the last symptoms for the last 2 months. And at present, she has shortness of breath of grade 3 to grade 4. She's a non-smoker and she has no positive history of environmental exposure, no long-term drug history, or no history of old exposure to dust or any exposure to any cotton industry. Coming to CTD workup, patient has no history of any joint pain, no glasses, no dysphagia or DRD symptoms, no sicca symptoms, and no muscle weakness or no morning stiffness. Family history, there's no rheumatological illness in the family. Personal history, she has two children, both alive and healthy. On examination, she has a room saturation of about 92 at room and heart rate of 100 per minute, BP 110 by 70 or within normal limits. And on auscultation, she had mid-inspirated post crepitation around present. On local examination, we were able to find a fish mouth, and there was skin thickening felt over the bilateral cheeks.
Okay, I'll stop sharing and Bhavin sir.
Yeah. So you're able to see the images here. Just very quickly, this is the non-lung window study. There's nothing significant here. And then when we look at the axial images, we start from the top. We've got reticular opacities, typically at the periphery. And if you see, there's quite a lot of spatial and temporal homogeneity, some blurring. And then in the lower lobes, we actually get this appearance of subpleural sparing. Some traction bronchiectasis, no honeycombing. Uh, and again, a little bit of subpleural sparing in the bases. So very symmetric fibrosing ILD, but there is ground glass, so there is an inflammatory component. The pattern is an NSIP pattern, predominantly fibrotic, but also with some non-fibrotic component. I did look at the coronals and the sagittals. I don't really see a straight edge or sharp margins or anything of that sort. But otherwise, this is what the pattern is.
Okay.
Yeah.
So you said fibrotic NSIP,
And I would assume this is a connective tissue disease, ILD, because that would be the
CTD-ILD.
commonest. Yeah, it's a CTD-ILD.
Okay.
Bhavin, just a very quick question. In view of the presentation, which is rather acute, I wonder if some of the ground glass might represent some lung injury. And if it does, it would be an occult inflammatory myopathy, or maybe an overlap, one of those disorders with a touch of scleroderma, touch of myositis. But I can't remember seeing a scleroderma patient presenting more chronically with such rapid progression of symptoms combined with that prominent ground glass. Do you think lung injury here, rather than traditional inflammation, might be important?
It is possible, yes.
We don't have any lung function data, right?
I think I'll share those slides, sir, because we
Because
didn't see even CTD workup yet.
because we have a 92% room air saturation, which means she's obviously not too well, what I can see.
284. Yeah, this is the lung function data.
Ah,
I bet the DLCO, if you could measure it, would be in her boots, actually.
yeah.
Hmm.
So she's 92% on room air. So she's already low on reserve. So she's obviously presented late to get a lung function done. So that fibrotic component is significant, I guess.
One of
Any
those,
drug she's been on?
Yeah, we will just
Any drug she's been on before
we
this?
will he has not finished his presentation, sir.
Okay.
Gokul, go ahead.
Yes, ma'am. So on foreign investigation, we did a CTG World Cup, and out of which the RF factor was negative, and anti-CCP was negative, and C3C4 was within normal limits, and ANA was negative, and dsDNA was negative too, and CPK values and serum procal all within normal limits, and linear function test and liver function test, thyroid functions all within normal, with urine within showing of protein 1 plus. And next we did Simons test, which was negative, and then nail 4 capital testing was done, which showed few avascular areas only in the light fourth and fifth digits. And rib biopsy was advised to the patient, but patient was not willing for the same. And we did a extended ENA profile, which showed low 52 3 plus positive, which was significant in spite of ANA being negative.
Okay. I think we will ask Mithun. Mithun, this is the profile. These are the tests. What do you say?
Yeah, a patient is having RAW52 very significant positivity, and you can get RAW52 positivity without ANA immunofluorescence positivity. That's a very well-known thing. But if RAW52 is positive, what you have to look is SSA antibody. If that is negative, then look at the myositis profile. You need to do the myositis antibody profile because RAW52 is considered as a myositis associated autoantibody. Here, I think they have done something, but not full panel.
You have to do myositis panel.
Yes. We have to do myositis panel. This is some extended ANA profile.
So if I can ask Mithun, why you think that this RO52 can come positive in ANA negative also? Why it is like that? So it has no relation.
It is a cytoplasmic antigen. It can be
Okay.
sometimes cytoplasmic, sometimes nuclear. Most of
So
them cytoplasmic.
You suggest that they have to do SSA first, and if that comes
SSA is already included in this ANA
panel,
profile.
it is negative now.
It is negative.
So then we have to do.
You have to consider the myositis autoantibodies.
Sure.
that would seem to marry nicely with the CT phenotype, I think. And one thing I would say about the CT, not to comment on it per se, but if there is myositis, I've given up trying to judge how much might regress with aggressive therapy, actually. I mean, Sujit, you may well be right. There may well be underlying fibrosis that is extensive, but it can be surprising how much can regress. And that combo of lung injury and inflammation might account for a lot of what you see on the scan, Bhavin. What do you think? In terms of...
I absolutely agree. So it's very difficult to predict what will improve and what will not improve. I mean, sometimes we've seen even so-called fibrosis regress, and there are times when nothing improves. So until you have two scans at two different time points, one after treatment and one before, it's very difficult to say that. So this is just one scan.
Okay.
Mithun, row 52 SSA and row 60 SSB, what are the differences on these antibodies?
So basically, there are
Right.
Sjogren's
Sometimes the
antibody.
Rho 52 and SSA is synonymous? Oh,
No. So Rho's previous SSA is also known as anti-Rho. But that
that's what
SSA
I
is
thought.
that is actually Rho 60. That molecular weight is 60 kilodalton. And this
Okay.
this is Rho 52 means 52 kilodalton. And SSB is
Right.
48. Is basically that
Okay.
immunoprecipitant, that method, no? That's
Okay.
how they identify. They basically 52 is the weight, molecular weight.
Got it. So it's not synonymous with SSA.
No. Actually, SSA is 60 kDa, kilodalton.
Okay.
As
Okay.
if SSA and usually Rho 52 usually occurs together.
Got it.
That is suggestive of Sjogren's disease. But
Got
if
it.
Rho 52 alone is positive, that is not typical of Sjogren. We cannot call them a Sjogren. We have to look for likely myositis antibodies because it can be, it is a myositis associated antibody, not specific, associated antibody.
Sure. Because I often read about Rho 60 and then Rho 60.
Rho 60 is same as SSA.
Okay, Rho 60 is synonymous with SSA.
Yes,
Okay, got it.
Can I ask a question? Okay. Bhavin, this patient has got only 1 year history, and HRCT chest shows that very extensive disease with predominantly of, though it's you say that the fibrotic component, very less about traction bronchiectasis or there's no honeycombing over there. So this is a fairly acute fulminant lung involvement in this CTD-ILD. Is it correct to feel in 1 year of time, or you feel this is must be happening for a long period of time? Because probably in such patient, does the pulse of salmeterol will help.
Yeah, so I mean there are couple things here. Number one is that we don't always get a clinico-radiologic concordance in these kind of situations. You never know what was lurking before and then suddenly got precipitated. But whether a lot of it, because if it is myositis, we know that these can progress very rapid. In fact, now we've got this phenotype of rapidly progressive ILD, which is almost, suggestive of a myositis. Because in 3 months and 6 months, we've seen things going so dramatically downhill. And that dramatic downhill includes fibrosis as well. I mean, we've seen traction bronchiectasis and honeycombing progressing in 3 months in some of these myositis phenotypes. So I think it's a single scan only tells you so much. You need more than one scan to understand what is the behavior, the rate of progression, because that can only be predicted when you compare two scans together. So, I mean, you're right. I guess you need to treat very aggressively, but there's limited information.
Does that esophagus you feel is dilated like in how the scleroderma patient have, or it's a different type of dilatation?
No, it's not. It's just some aerophagia.
Okay.
Yeah.
I've seen this sort of disease develop in a fortnight from a standing start in myositis. I know we get a selected group because we have ECMO, but I would have said this was not at all or an inflammatory myopathy lung disease. And what we also know is that in some series, a third of the time, the lung disease develops before the muscle disease declares itself. And occasionally it's myositis and amyositis. You get the serology in the lung. And the worst disease seems to be when you're not getting a muscle phenotype as well. So this is the most frightening connective tissue disease to treat, because you look at this and you think there really ought to be a response to therapy. You should be rescuing these patients, but some of them just inexorably progress whatever you do.
Yes.
And the mistake is not to go in with all guns blazing at this stage.
Yeah.
Also, I thought, Bhavin, there was a subtle suggestion of a straight edge sign on the coronal images.
No, that's what I was trying to show, that it's not really there. Let me just show it quickly again. So that's why I brought in, sorry, the coronals here. And you can see, I mean, maybe
bit.
there was one earlier, but right now, if you
that's
have to
fine.
think about it, then it doesn't exist. It should be very straightforward
Sure,
and easy
sure,
to look
sure.
at.
Fair
But
enough.
it's symmetric.
Yes.
It's everything you'd expect from an NSIP, perhaps with a little OP overlay. I didn't bring that up, but it's all part of that.
Okay.
But that would
Okay.
be another feature pointing towards an inflammatory myopathy phenotype.
Yeah, I think we will move on to this. Whatever.
Here you have to do the MDFI. It is very possible that anti-MDFI can be positive.
We can't do alone, right? We have to send
we have to send the panel.
So questions.
ANA negative, Rho52 positive, L1 positivity can occur because it can be a cytoplasmic antigen also.
Second also you can attempt. Third also you can attempt.
It is look like a myositis related ILD for me. Rho52 L1 positivity is not synonymous with Sjogren or scleroderma. Rho52 associated with anti-SSA or Rho60 is suggestive of Sjogren, not Rho52 L1 positivity. Managing Rho52 positive ILD, that Rho52 is a myositis associated, not a specific antibody. Therefore, we have to look for other causes like myositis. Immunomodulator of choice in Rho50, that is the same. Depending upon if the myositis, you have to treat aggressively.
Nathan, I have a question for you. You've got the nail fold capillary signs, and we've heard about skin changes. Do you think this amounts to a scleroderma element, or would you tend to choose to overlook those at this stage?
That nail fold capilloscopy can be non-specific also. If there are very significant capillary fold dropout, then you should suspect Sjogren, scleroderma. But based on that alone, I don't think we can diagnose this scleroderma or Sjogren or any CTD. In myositis, you expect a arborization pattern. New capillaries will be formed. Giant capillaries will be formed. That is not seen. Here, some avascular necrosis. Don't know what. Sometimes it may be a vasculitis. Only on 2 digits use it was seen. Based on nail fold capilloscopy alone, it is actually difficult, but sometimes it will help in your diagnosis.
And I think there were 2 more questions for. Yeah.
I think these are
yeah,
cannot answer. No, we have to find the cause and treat aggressively. That's what. If it is a myositis related ILD, sometimes whatever immunosuppression you give, patient may not improve. First thing is to stabilize the patient, then only about long-term treatment. I think we have to do the myositis profile and then decide on treatment. Initially, as sir was telling, we have to pulse. That's how usually we deal.
Yeah.
I'm worried enough about this patient. And even if you don't find a myositis, I think treating as for a myositis phenotype is correct. And whatever you use, you want rapid action with. And unless you get a striking quick response to steroid, I would consider IV cyclophosphamide. Get in quickly here. And the issue is whether you then use, say, TAC as the immunomodulatory oral agent that acts most quickly, or I don't know. I don't think you can use both cyclophosphamide and rituximab, probably, although Nathan might well have views on that. But whatever we do, the crime is to miss an opportunity.
Yeah, cyclophosphamide supposed to be more quicker acting than rituximab in this scenario. Combining cyclophosphamide and rituximab, I have tried in MDFI but failed because the disease progressed actually. But that has a risk of infections. High dose steroids plus cyclophosphamide plus rituximab, definitely they can get infections. It's a double-edged sword.
Hmm.
I prefer cyclophosphamide in this case, but rituximab is also we can give, but all depends upon the.
I suppose if you get a partial response, Smith, then you could be considering adding rituximab downstream for long.
Yes.
Um, the great mistake here would be under treatment. I would rather risk over treatment than under treatment here.
Hi there. I'm just I have one question. That is basically when you're using cyclosamide, and we do have different protocols. One is the recital protocol, that is IV cyclosamide 600 milligram per square meter monthly. Other one is the Cyclops protocol, that is for these vasculitis protocol, that is 15 milligram per kg. And then other one is Eurolupus for the lupus nephritis, that is 500 milligram 2 weekly. So what is the preferred option here? The dosing of cyclosamide.
See, if it is a vasculitis, vasculitis, you have to give 15 milligram per kg.
No, I'm
But
just wondering
that is a more stricter dose. For initial dose after 2 weeks, you have to repeat. If patient is elderly, it may be difficult to give that. Other urolupus definitely out. We cannot give in this case, or any ILD cases. Usually don't follow the urolupus, which is a 500 milligram once in 2 weeks. It's a low dose cyclophosphamide. Other is a modified NIH regime. That means 750 milligram per meter square, which is a pretty good dose, especially even if patient is 50, 60. Usually we follow either 600 milligram. If it is if we want to treat aggressively, we follow the NIH regime. Otherwise, 600 milligram per meter square is also okay. In this case, 750 milligram per meter square once a month.
Okay.
And that's it. And vasculitis, it is a once in 2 weeks for the first 3 doses. Then you increase to once in 3 weeks, like that. You have to monitor and give. That is basically approved for vasculitis, anga vasculitis.
Sure. Muli
And
Mohan, sir. Mohan, sir.
The choice of oral agent to be introduced, not necessarily instantly, but in the near future, what would you choose, Smith? And would you go for mycophenolate, tacrolimus? What would you use?
If patient improves with cyclophosphamide, I will consider mycophenolate mofetil, definitely.
Okay.
A safer drug.
Not that tofacitinib. Okay. Muli Mohan, sir. Muli Mohan, sir, you wanted to say something? You are muted. Yeah, your voice is not coming. We need to move on. Okay, fine. I'll move on to second case, which is going to be presented by my colleague, Dr. Nitya.
Yeah, sorry, I was unable to unmute for some time.
Sure.
So
Okay.
I wanted to ask, would this be a patient whom you would initially start with IVIG or Plex, Dr. Mithun, get some quick control and then start the cyclophosphamide? Would that be an option?
Basically, in MDF5, I have tried this IVIG thing, like we give in what you call COVID ILD. The last MDF5 I have tried IVIG, actually with rituximab, with hydrosteroids, followed by tofastinib. That is one regime which has been tried in MDF5 ILD, but yet to see the result. Well, if you are giving rituximab, definitely giving IVIG will help to counter the infections, because that's some way it protects for at least for 1 month, it will give some protection.
Okay.
Apart from the anti-inflammatory effects of IVIG.
Okay. Okay, we'll move on to second case. Nitya, you can start.
This is a 69. Am I audible?
Yeah.
This is
Go
a
ahead.
69-year-old lady. She came to me first in October 2024. And actually, at that time, she had undergone a surgery for varicose vein laser surgery on 25/10/2024. And on the first post-op day, she developed an episode of desaturation. And they suspected a pulmonary embolism and did a CTPA at that time. And there was no evidence of any major pulmonary emboli. But There was incidentally detected ILD, which was reported in the CT, and for the evaluation of the ILD, she came to the institute. And on inquiring about the history, she just claimed a history of a dyspnea on exertion of grade 1 for the past 6 months. And on probing further, she gives a history of exposure. She used to go to temple daily, where she was exposed to pigeons, and she used to light agabatis at home. And there's a big pond near her house, so obviously the area around that place was damp, but there was no exposure to any chemicals or anything. And she gives a history of COVID infection in 2022, for which it was a category A, and she was in home quarantine. And she has systemic hypertension, for which she is taking amlodipine 5 mg. And for the past 2 years, she has noted a vitiligo on the corner of her lips. There's no history of any recurrent oral ulcers, a Raynaud's phenomenon, or any pain in joints. There's no history of any pulmonary tuberculosis or pneumonia, or any rheumatological illnesses in the family. And on examination, her lumen saturation was 94% with a heart rate of 112, with a BP of 140 over 100. And there was a vitiligo was noted, and the thyroid swelling was there. And on examination of the chest, there were mid to late inspiratory crepitations in bilateral, infrascapular, and interscapular area. And I sent the initial investigations. Then when they came back to me, she developed she gave a history of diplopia and was hospitalized with that. And she was diagnosed with a right occipital infarct. It has a left homonymous hemianopia. And at that time, I took a second opinion of the CT thorax from our radiology, which showed a segmental pulmonary embolism to be ruled out, and they suggested a CTPA. Next, coming the images.
So we have two sets of images. First is the December 24 CTPA, which shows these subsegmental emboli in both lower lobes. They're very well seen in the coronal plane. And if you look at the lung windows at the time, it does show an interstitial lung disease, but these are expiratory images. So we'll just, move from there and come to the current scan, which is of February 25. So Nitya, should I talk about that?
Sir, can I say the rest of the history in between?
Yeah. Please go
Yes, sir.
ahead.
So after this CTPA, which showed a pulmonary embolism, and at the same time, a bilateral lower limb Doppler was done, and it showed the deep femoral vein at the mid-thigh level appears dilated, showing a partial deep vein thrombosis, and anticoagulation was started. And after the anticoagulation was started, that's on 10/12, she developed an acute ischemic stroke, which was involved the right occipital lobe and the splenium of the corpus callosum. And now her current status, that is in February 25, the dyspnea has progressed. Though from her stroke, she has recovered, and these were the investigations. So the notable investigations were she had a high elevated ESR of 79, ACE was 62, the RA factor and ACP was negative, ANA screen showed a 2 plus. The other investigations were essentially within the normal limits. These were done as a part of this connective tissue workup when she developed a stroke. And in view of the exposure history, I sent an HP panel, and as well as an echo was done. And the HP panel came positive for almost whatever we did. It was positive for multiple funguses as well as pigeon proteins, and the echo was normal. And the ANA profile showed was positive. And with this, we went ahead with a repeat CT thorax. And these are the these are the repeat PFT, where the serial PFT values. If we look the FVC, it's the FVC values, it is almost the same. It's 0.97 and 0.9, 55 to 49%. But in the walk test, initially she could walk almost 300 meters, but over the period of 3 months, it reduced to 240 meters, and she developed a grade 2 dyspnea also. I couldn't repeat the DLCO after 3 months. And these are the current medicines which she is taking. So this is
Dr. Nitya, APLA workup, antiphospholipid antibody workup, anything done?
that is also done. That was negative.
Oh.
Yeah, so this was the CT scan done in February 25. And in fact, this is the supine inspiratory on the right side, but it's got a lot of blurring. And then the expiratory images are also showing a lot of, some blurring. Sorry, these are the inspiratory images with blurring. The expiratory images are better than the inspiratory images, but the prone images are the best. So we're just going to focus on the prone images here. We see reticular opacities with an axial distribution that is going from the hilum to the periphery. And then as we come inferiorly, you see this hexagonal pattern of disease, which is quite interesting. It's also showing the triple density sign, or, normal lung, lucent lung, ground glass, though I'm not sure how important that sign is anymore because you see it in everything. But that's the pattern. It's an axial distribution, reticular opacity, something that, we would reasonably, without hesitation, say is highly suggestive of hypersensitivity pneumonitis, predominantly fibrotic. There are some areas of subtle traction bronchiectasis, no honeycombing, and there isn't a lot of ground glass per se. There's just these areas of lobular air trapping, which we see in these expiratory images. It's always, when we look at these in the coronal plane, it's very interesting how you can appreciate that lacy pattern and the axial pattern so much better. So basically, I would just say that it's HP.
Okay, I'll go through the questions.
So should I say the summary for?
No, it's okay. So these are the questions. Can anybody want? Sir told it is looking more like radiologically CTD. Nahi hai, it is HP. Rajan sir, Prahlad Prabhu Desai. Anybody wants
I
to
don't
try?
know the significance of that antibody M2. Mithun may be able to what.
Yes.
So the M2 is basically PBC, primary biliary cirrhosis, not related to this thing. And anti-SS is also 1+ positive, but Schirmer is negative, no? Have you done Schirmer in this way?
Schirmer was not done.
We have to, in this case, ideally we should do the rule out dry eyes also. If dry eyes is there, I think a lip biopsy may be needed to confirm the Sjogren syndrome, but that may not be. Sjogren syndrome can have hypersensitive pneumonitis also. It may not be related to the ILD thing. Sjogren is such a common disease. We can be caused with many of these diseases.
She has a lot of drop in FVC compared to her DLCO. And I'm just wondering if there's an extra pulmonary component here of her lung disease. Nitya, is there any muscle issues or any other issues? Is she underweight, overweight?
No, actually, when she came to me in October, except for that varicose vein surgery, she was fine and healthy. And just because of the varicose surgery, she went for that issue only. She went for the hospital, and she was claiming that she has been going to the hospital the first time in 30 years for that surgery. No other issues were there.
And she's 29 years old, right?
No, 69. 69.
Professor Wells.
I agree that this is classifiable, but I don't think I'd be putting together some of the clinical features. I'm a little insecure about a couple of things. Maybe the clotting is not part of the primary disease process. If it was, however, even though you're anticardiolite negative, I would be thinking about immune dysregulation. Some vasculitis patients have both clotting and, well, they have quite a lot of clotting. Lupus anticoagulant, you won't necessarily pick up by doing anti-cardiolipin antibodies. At least we have to measure this separately. But on the other hand, the inspiratory squeaks point quite strongly to HP. So I think it's fair enough to make a working diagnosis of HP. And for a start, that means you'll evict the antigens very vigorously. And I'm not sure that management will otherwise change for the two possibilities. There's nothing on the scan to suggest a UIP pattern as I understand it. And so, in essence, I would not do a lung biopsy here, I don't think. You're going to have to accept with that very low spirometry that it would be a higher risk procedure. And I'm not sure that the biopsy would actually change management. I know some people would. We could have a straw poll on it, but personally, I would be worried about it.
I think considering the working diagnosis of hypersensitive pneumonia, but the two important vascular events we have to keep in mind. One is a DVT development, okay, and second thing is this the stroke patient had. So though we treat her with a HP, I think we have to monitor whether patient develops pulmonary hypertension or third any other vasculopathy, probably a possibility. So, but the treatment doesn't change because both the disease will require mycophenolate and steroids or whatever it is, along with the anticoagulants.
Okay, sir.
The issue of pulmonary hypertension, I was actually quite reassured by the KCO level and also a 6-minute walk test of over 300 meters without huge desaturation. So if pulmonary hypertension was part of the picture, and you add that to the amount of disease on CT, I'm not sure she'd be managing 300 meters plus on the 6-minute test. But the concern is a vasculopathic process, and that is where we could misdiagnose the case, and that is why it has to be a working diagnosis of HP.
Yeah.
So the other thing that worries me is the superficial thrombophlebitis, the deep vein thrombosis, and the stroke. I'm also a little worried about an underlying malignancy. So I'm just wondering if, apart from the vasculopathic process, should we be ruling out in a 69-year-old fit and well until now, and then suddenly goes downhill? Worth looking for a malignancy. I would probably want a PET scan also.
Okay, sir.
Yeah.
Okay, thank you, Nitya.
Okay,
I
sir.
will
Thank you,
move
sir.
on to third case, and this is Miss M. Bhavin sir. So the reason I am presenting this case is just 2 weeks before we presented one young lady with a similar presentation, and this is kind of thing which we want to highlight, that what happens if we don't do transplant. So this is a case of 58 years old lady. I am seeing her since 2010, and she is from Thrissur and non-case of ILD. It was that time diagnosed as a UIP pattern, mixed connective tissue disease by my physician. And 2003 she was diagnosed as rheumatoid arthritis, and she was started in DMARDs. And 2006 again she developed something and they changed it to methotrexate. She developed herpes. 2010 another infection. 2020 she presented with Raynaud's phenomenon. In 2024 she had another fungal infection of nails. When this all while she will be following up with physician and myself, and in between only last 2 visits she is going to Dr. Mithun also. So her presenting complaint to me, why I'm presenting is for last 6 months I had seen that her exacerbation and her fluctuation of PFT or other values has increased. She was very stable throughout all this while, and for last 6 months she started developing more and more complaints. That is why we decided that we should present her. So presented with cough and voice change, viral fever with headache. That is what the last time happened. Bilateral knee joint pain and ankle joint swelling was also there. But she is well preserved, saturation of 98, everything else is normal. Predominant right-sided crepitations, left side are less. ANA was 4 plus, course speckled at that time, and I don't think I repeated it. It was worked up long before. And this is her spirometry. And I will spend 1 minute that you can see that 2010, she was having 2 liters of FVC, and at 2025, 2024, November, December only we had done, and that was 1.65 liter. Over 15 years, no much change, I would say. And DLCO we have done only last year, last month, that was 75%, KCO of 74%. I did 6-minute walk test almost each visit every 3 months, and 98 to 97% her baseline saturation does not go desaturation, 360 meters. However, the distance from 480 meters in 2010 became 360 meters in 2025. Now that can be age related also, and I would like Bhavin sir to share the CT scan images.
So, whenever, before I go ahead, that last case that was presented by Nitya, she mentioned that somebody had reported a Mueller score in the first slide that she showed. And that's Nestor Mueller score. And I'm sure he'll be extremely proud to see that somebody is using his score, but there is no scoring like that. That was all for some clinical trial that was done, and it has no practical relevance anyway. But whenever you see scans from 2010, soft copy images, that's one of those great moments in life because it's so rare for that to happen. And if you see this here, that's from 2010. It's not a volume scan, but it doesn't matter. And we see these reticular opacities in the non-dependent upper lobes. And then as we go more inferior, there is asymmetric disease. There's honeycombing and cystic change with traction bronchiectasis. The esophagus is dilated. So this fits in with a CTD ILD with a, if you wanted to label it, a UIP-like pattern. And that's about it. There's no ground glass. There's nothing else. This esophagus is distended like you would get in scleroderma. So I guess that fits in with the mixed connective tissue disease. There is a scan in 2012, but that's in expiration and it's not very helpful. There's no change. But then we have the current scan to look at. And first, I'll just show you the scan. Sorry, expanded here. And then we'll look at the comparison. So here we see the reticular opacities, the subpleural cystic areas, and honeycombing. We see that now. So obviously there's progression. The extent of cystic change, the honeycombing, all of that has progressed. The left lower lobe now is diseased. Clearly, this is more a UIP pattern, but there's a lot of ground glass now. So the superadded ground glass is like an acute exacerbation, lung injury, inflammatory component, etc. But having said that, over 15 years, the rate of progression, and this is what we were talking about in the first case, is it's not that fast, I mean, rapidly progressing. In 15 years, if it's just gone from here to here and you've just developed so much, that's in fact one of those slow progressors that we have. So it's just nice to have 2 time points. That's about it. And there's nothing on the mediastinal windows anyway. So basically consistent with the history, it is a CTD ILD and there is progression with an acute component now.
Yes, but as the reason I put it is like, sir, we were discussing last time that we don't know how is the nature and should we do transplant or should we not do transplant? And
when would you have done transplant?
No, not for her, for other patients. So what I'm trying
She's
to say
lived
is,
longer than any transplant
yeah,
patient has
that is
lived so
what,
far.
15 years, and as you can see the PFT values and all, it's not that bad. So that is why we should not be like so fast in preferring for transplant. Maybe those people who are in favor of transplant may not like it. So isn't the disease relatively stable over 15 years, Bhavin sir? You said yes, right?
Well,
Relative.
it has progressed, but relatively stable given what we see in other patients.
Yes.
But right now there is a problem. There is some acute exacerbation, ground glass, whatever. So that needs to be addressed.
Okay. and she was not very keen. This is the same patient, Mithun, which I discussed, that she has diarrhea after taking MMF and not tolerating Azoran. So on and off worsening and recurrent exacerbation, anything more to offer? And with that, I will stop sharing my screen. Yeah.
With MMO, she had diarrhea.
That is what she was telling, no? Yeah.
Was she on idoflanib?
No, nothing. Only some very minimum maintenance dose of steroids of 5 milligram, which we make once in a while increased as exacerbation comes, along with some prophylactic antibiotics. That's what I'm treating, and she was relatively stable. Only for last 6 months, she has started coming more frequently. That is why
amount of salt we can change. Amount of S like 360 milligram we can change, which is more gastric protective.
MMFS, more gastric protective. Okay. Anything else anybody wants to say?
Probably a little more proactive about her reflux disease. She's got a fairly significantly dilated esophagus. There's also a hiatus hernia, Dr. Bhavin.
Is there hiatus hernia, sir?
Let me see. No, it's just the esophagus. Well, there is a small hiatus. You're right. Yes. It is there.
Perhaps that's the only other thing. She's done well. More medicines probably will poison her more. So, I mean,
yeah. Professor Wells.
It's difficult. I mean, it's an outlier in the phenomenon of UIP, and one we've got to expect just occasionally the patients with a CTD where the UIP doesn't behave like IPF and switches off. We don't know at what point the progression occurred within the time interval. So I don't think management is geared towards the UIP element. And then the moment Bhavin is identifying an acute problem, I think something's got to be done once you've thought about drug-induced disease, and basically something has to be done to try to reverse the acute element, I feel. So without poisoning her with too much therapy for too long, I would consider a short, sharp trial of steroid here. You don't know how long that apparent acute process has been present, but it does seem strikingly different from the past. As Mita, the symptoms have worsened relatively recently.
Yes.
Yeah.
Yes.
So I wouldn't be committing to long-term management at this stage, but I would be a bit concerned about not addressing the acute element and trying to switch it off.
Okay. No antifibrotics, sir?
Well, you're treating the UIP element with that, and in 13 years, there's been relatively little change. So an antifibrotic drug wouldn't be my first choice. Now, you might put it in, but I think first and foremost, I'd go for a response with possibly methylprednisolone and try to switch off the dangerous element of this, which is whatever has developed acutely. And then you take stock after that challenge and decide what you'll do downstream.
Can you show us the lung function again, Asmita?
Yeah. Somebody was talking?
No, I was wondering actually whether atypical infection like PCP it could be a possibility here with diffuse ground glass, because Dr. Shankar, I would value your opinion whether this could be PCP, whether is there any, any clues?
There are no clues. Once you have this ground glass like this, it all depends upon the clinical situation. So it could be anything from some exacerbation to part of the inflammatory component of the ILD to superadded infection. Can it be PCP? Yes, but there's nothing on the radiology that allows us to say that.
At the moment, the question is whether there should be a BAL before you consider immunosuppression.
Okay, I will try to convince her. But as such, na sir, whatever happens, like when I give a short course of steroids, she improves, and then she will be like, "I'm fine. Why you want to do anything?" So, as you rightly said, maybe if I'll give her a short-term sharp steroids, for a little bit more duration than I'm giving, maybe she will improve. PCP diagnosis as such, in BAL in our hospital is not very easy, but I will try to convince her, sir.
Or you cut.
Other,
Yeah,
sorry.
but Asmita, she's lost about more than 20% of her vital capacity in the last 3 years, 3 to 4 years. So if you are not going to get back to 2021 values or
Okay.
close to that, you will have to start an antifibrotic. This can't be explained only on aging.
Okay.
Right. So I think the other thing is the plus about getting a response to steroid is that it then validates use of immunomodulation to preserve the gain in the longer term. So it's as much a treatment that guides you on long-term treatment as anything else. I certainly wouldn't be committing to a rigid long-term approach at this point.
And your
Yeah.
DLCO is
Further,
probably wrong, I think. 75% can't be. There must be an error there. 48 has gone up to 75.
Mm.
You need to repeat it, I think, in 2025. Where's the FEC with that? How has the DLCO gone up? That's a little odd.
I think she didn't put the FEC value. I'll check.
and further, Smith, I mean, if we do have the serum beta-2 glycan, I mean, it's a very sensitive marker for PCP. I'm not sure its availability, but it is very sensitive marker for biomarker for PCP if it is available.
Yeah, we can
But
outsource it. I have done it, but
is
yeah,
it is available.
Yeah,
it's
this patient,
available. But yeah, I won't like
this
okay,
patient is
fine.
best BAL, done a BAL, and
Mm.
finished all the possible infection causes, pulse the patient, and add probably your mycophenolate S, that is sodium salt, so that
Yeah.
small and then gradually.
Yes, I think that sounds logical. I'll do that.
Asmita, could we have one more look at the lung function page? I want to get my head around the DLCO and also the 6-minute walk test reserve. 360 meters did not desaturate. So that is the sort of 6-minute walk reserve that would tell you that the DLCO can't be severely reduced, I believe. And so it's a slightly confusing picture, isn't it? You take the CT aboard in the ground glass, you're worried about an acute element, and yet the DLCO plus 6-minute walk test is saying that perhaps the impact of the acute element is not that great. Nonetheless, there's quite a lot of ground glass, and your worry would be that it will evolve and progress. And so I still think you have to address it.
I think better to get a fresh lung function in 2025, Asmita. There's no FEC there.
I
I
think
agree
she
with
has, my
yeah.
my my PG has not put it. I
No
believed
worry.
it.
When
DLCO
was the
would have been done.
2024? Was the 2024 early 24 or
So
end of
I believe it will be every 3 months. So it will be somewhere in September, October, or November, December of that month, and the last DLCO will be of March or February. That's it.
Okay.
Yeah. So we will move on to the fourth case. That is also a simple case, but we have a patient who was recently admitted. He came to me in October, and I believe we discussed that patient, and that time we discussed for the cystic ILD. So he is a 71-year-old farmer. Background was obstructive airway disease. He was ex-smoker. He was hospitalized in September, and that time CT scan was taken, and incidental finding of some cyst, and so he was referred to us. Now this time within 3 months he got admitted again, with cough and dyspnea, loss of weight in 5 kilogram in 2 months, and the family was concerned that whether the previous disease is progressing. When he presented, his saturation was 93. He had bilateral peating edema, bilateral V's. And this is his myositis profile. When he came first, we did it. and it was inconclusive. So was his ANA and everything else. First time when we came, we did bronchoscopy and lavage also. Everything was negative. This is his spirometry, and spirometry was 60% and FEV1 was 51% with a ratio of 87. DLCO was high again. I don't know why. So I believe that something is wrong that, and we will do a CT image of the patient. So basically, I made a diagnosis of COPD and we treated as a COPD. And this time also, I felt it was a COPD exacerbation which has worsened. But since the family was concerned that whether the disease is worsening, we did a repeat CT scan. So we have 2 CT scans for him.
So that's the first CT, the 2 bottom rows, and this is in October 24, where there's a lot of inflammatory bronchiolitis with a lot of these clustered centrilobular opacities, nodules. And then obviously there are a lot of these cysts which actually don't even show walls of any significance. So most of the times, any cystic disease would have some form of perceptible walls. And so, while the cysts are there, the predominant component is just these presence of widespread inflammatory bronchiolitis. I just did some jugglery here. We use what are called minimum intensity projection images. And that actually shows you the cyst burden. There are a lot of cysts, and much better appreciated on this projection image than when you're looking at the individual scan. But there is the intervening lung is normal, and frankly, at this age, unless there are additional findings, this is probably not really clinically significant. And then the current scan of 5th March has expiratory images. There isn't a lot of air trapping. But if you look at the inspiratory image here, all those areas of inflammatory bronchiolitis have more or less cleared out. The cysts are better appreciated. Yes, there are a lot of them, but they're all very well rounded, subtle perceptible walls, if at all, and the intervening lung is normal. The cyst burden is the same, it hasn't changed at all. But whatever was a superadded inflammatory bronchiolitis has significantly improved. That's all there is to it.
What's the gap between the 2 CTs?
October and March.
Yeah,
Okay.
October 24 and March 25.
Yeah, so the thing was same. The family was concerned that is the disease progressive, and do we need to do anything for him? So presently, I have started him on single inhaler triple therapy for treating his symptoms, and he's better with that. I believe this time also it might be infective exacerbation, though we didn't see anything on the CT, right, sir?
Yeah, we didn't see anything.
Yeah. Anybody wants? Otherwise, we can move on to the third last case.
No family history of pneumothorax, cystic lung disease.
His son is there. I didn't do anything. So this kind of patients, should we send this FLC engine just like that, or should we not? Because I didn't do CT scan for the son. Son is concerned, sir.
Just asking if there was any family
No,
history
nothing.
of lung disease.
I mean,
No.
asymptomatic 70-year-old with incidental cystic lung disease, you don't
Leave him alone.
touch.
Sure.
Okay. Okay. Okay.
Asmita, further, I mean, considering the recent infective exacerbation, how safe to continue the inhaled steroid in your case? Whether there's any evidence of Th2 inflammation at all, or I mean, whether we would manage with
He's on triple
bronchodilatation only?
therapy. It's a part of that. So I have continued because he was already on and came
Considering
with
the infection.
exacerbation. I believe that I will step it down.
Is he polycythemic by any chance? I mean, that DLCO is so high. It's strange.
I didn't see that. Let me see. I'll check it, sir. We didn't put CBC report over here
Sure.
because okay. Anybody wants to say anything? Otherwise, moving to 5th case. Professor Wells, Prabhu Desai, sir. Nothing.
No, I've got nothing to add. I think the approach you've set out is correct. But he also
Okay.
favors intrinsic airway problems.
Hmm.
Okay, so this is a 40-year-old male patient. He's symptomatic since October 2020. He'd had 2 endoscopies done in the last 4 years when I saw him first in 2020. Had COVID pneumonia, needed oxygen for 5 days, treated with steroids, pirfenidone, rivaroxaban. A lot of this all empirical, followed by nintedanib for 3 months, and met me in June 2021 with complaints of exertional dyspnea, reduced appetite, walk desaturation. A CT in March 2021 showed significant resolution of the COVID pneumonia, but there were random nodules on the June 2021 CT. An endobronchial and transbronchial biopsy was done at that time. Unfortunately, I don't have the slides because it was 4 years ago and I didn't realize that I would have to revisit this case now. Showed no granulomas, just interstitial pneumonia. The histopath was reviewed. The TB cultures were negative. ACE levels were 22, normal echo, and the histopathology reviewed at KEM by Pradeep Vaidishwar. Sharda would be knowing him. Alveolar septal widening with lymphocytic infiltrate. No miliary lesion. So what we did was, because he was these were miliary looking random nodules on the June 2021 CT. We said we'll treat him with ATT and steroids for about 3 months. Stopped ATT on his own after 6 months in January 22, after the Omicron wave. And then he came back and I said, look, you can't stop it in 6 months. This was miliary TBs because he felt better. So we restarted after 2 months and he completed a total of 1 year ATT. Our working diagnosis was probably a sarcoid TB overlap. And maybe Bhavin would like to show the initial scans.
So I have loaded everything together because that just made a lot of
No
sense.
worry, no worry.
But we'll go through each. We can just unpack that. So, okay, this is June 21. And a lot
Yeah.
of these are COVID-19 changes. And then we have these 2 to 3 millimeter sized, randomly distributed, same sized nodules. So they are miliary nodules. They were not there during COVID. And the commonest cause of miliary nodules in our country remains miliary tuberculosis. So that was my diagnosis in June 21. In August 21, those nodules had mildly reduced in number and in density. And most of these other lesions, the peribronchovascular lesions, kind of remain the same. And if you just look at the bottom two sets, you'll find that apart from the nodules improving, there was no other significant change. Then he comes in October 22, at which time the nodules have pretty much gone. So if I just magnify the images, you'll just see that these peribronchovascular opacities remain the same. But all those miliary nodules have kind of gone. But having said that, it's, these opacities here in the left upper lobe have actually kind of progressed a little bit. And that was, I think, a little disconcerting. And we were therefore wondering whether it was a TB sarcoid kind of situation. And then so do I go to December 23? Have you reached there? No, no?
Yes, because there was nothing much happening. Yes.
Yeah, so December 23, again, we have these lesions continuing to be present. But again, now there's no significant change. It's more or less looking the same. So while there was a little increase, I think, in the left upper lobe lesions, on the third scan, more or less from 21 to 23, except for the regression of miliary nodules, the scans are more or less looking stable.
Okay. Could we have the next slides, Asmita? If you could, yeah. I really want Murli, Athol, Prahlad, and Amila's thoughts here because this is really tricky here.
Bhavin
So
said if you
then,
will stop sharing.
Yeah, did
yeah,
that.
and then Bhavin will have to come back because what's happened? Okay, that was the initial CTs, and the next slide. So I'll just recap. He was treated with ATT steroids, stopped ATT on his own, and then we finished 1 year. Everything was stable. He didn't come back for too many follow-ups except his routine lung function. He was off steroids, off ATT. But he got admitted last year with a left lower lobe pneumonia, and Bhavin will show those scans. And he'd lost more vital capacity. And in May 24, he said he's unable to rush things. He's able to walk with friends of his age, but not when he wears a mask. Why he wanted to wear a mask while walking, I'm not sure in May 2024, but he was doing that. Now, and we are now in February 25, he complains of February, March 25. Now, he complains of breathlessness on walking and even doing basic housework, mild while bathing, and increased dry cough when speaking loudly and laughing. Next slide. And these were his lung functions. So he was low even way back in July 21. And he sort of got a little better, 22, 23. And so we said his DLC has always been a bit on the significant lower side, mild desaturation. And now he's lost even more vital capacity. And his DLCO is still low, and he's desaturating down to 85, but he can manage a fair walking distance despite that. His KCO, if I recollect, was normal. And so the more recent CT, Bhavin, you'd like to show that?
Yeah. So if we come back to that, then we can see that in May 24, he had this left lower lobe pneumonic consolidation, which has then gone away in Feb 25. But I think what was disconcerting in Feb 25 is all of these nodules have started coming back. And at this stage, you can actually make out that they're subpleural nodules. Some of them, while there aren't very typical, there are some fissural nodules, but these now don't look typical miliary because there is some kind of a distribution that we have with them. And that's weird because you've got them back in Feb 25. And then in March 25, that PET was done, which shows uptake in those peribronchovascular areas. You can see that here, which means that even though there isn't, significant progression of the disease, you do have uptake suggesting some level of activity. There is an increased density, however, to these peribronchovascular opacities. Um, and that's kind of what it is. There is probably an element of fibrosis that has increased in the lower lobes here and here because you see traction bronchiectasis, but that's mainly in the left lower lobe, and that's where he had the pneumonic consolidation. So I'm a little not sure whether that was a confounder. If we just look at these two scans, right, the 7th March and the 3rd June 21, we'll realize that these peribronchovascular opacities have become denser. They may not have increased in size, but the morphology has changed. The nodules have changed in pattern, and there is that so-called possible fibrosis in the left lower lobe. So that's what we have.
Right. And so we did discuss with him, I think the questions I'll put up, we did discuss with him this time and about a repeat biopsy. He's quite frightened about that. But our interventional pulmonologist met him, suggested a repeat transbronchial biopsy with the lymph node and other EBUS TBNA. My question was whether we should proceed to VATS biopsy here because we don't have a high volume cryo center in Mumbai. The easiest thing would probably be to start steroids. that's where we are. So open to discussion.
Murli sir, Prabhu Desai sir, anybody.
This
Somebody has to start, but I'm trying to hold back because I view.
Yeah. Nobody's starting, sir. You start.
Well, I view you as the true experts on the spectrum of TB in a high prevalence country and how it overlaps with other disorders. It remains possible that this is just sarcoid. I think we've got to say that.
Yeah.
It's difficult to think that ongoing TB is producing this after a year of therapy and got a response to steroid, which you lose when you stop the steroid. So it's difficult to make this into TB. I think it's perfectly possible that there was TB which provided an antigen which resulted in sarcoidosis. But my concern is, what are we missing outside this spectrum? And for that reason alone, I think I would favor getting further tissue. We would probably do a cryobiopsy rather than a VATS as a first choice. The DLCO being what it is, you might want to go for the less invasive procedure, I suppose. And then finally, that brilliant 6-minute walk test gives the lie to my comment in the last case, which is that the DLCO couldn't have been really low with the good 6-minute walk test. What you do know is that there's no pulmonary vascular element here.
His echo has been normal, at least. But yeah, I was wondering whether we should be doing cardiac MRI here at all, or.
Yes, I think that that would be a good thing to do. I think maybe you would do that before you subject him to a biopsy procedure, because clearly a classical late gap pattern, which could go with a normal echo, it would shift you very nicely to a sarcoid diagnosis and management. But unless you get something better, this is the sort of case where we might be ambushed. And I'd be inclined, I think, it's one of those discussions with the patient where you're presenting it as a close call and the patient has to buy into it without you persuading. I'm bringing coals to Newcastle here. You know, not biopsy conversations, but I'd be inclined to biopsy, I think.
Yeah, I think they are also wondering when the first biopsy reviewed by 2 pathologists was inconclusive, and we just can't get hold of those slides, sadly. But there was no granuloma there. Are we going to get it this time? And what are the chances we could miss or not have granulomas despite this being sarcoid at all? Is that possible?
I'm more concerned about an alternative diagnosis, and we're being fooled at some level. And with all of the sarcoids before, no granulomas on biopsy is an outlying feature for me. If there's no chance,
I didn't understand that at all. What did you mean? No granulomas on biopsy?
it worries me for sarcoid when you're already saying that sarcoid is the dominant process, and you do a biopsy at the time you have such profuse nodules. Not seeing granulomas bothers me. It's another reason to revisit the histology, I think.
Sure. So we have spoken to him about that, and he's waiting.
I can't come up with an alternative plausible diagnosis outside your description.
Sorry.
Thank you.
The consolidation part was the most recent CT?
No. That was in May 24, resolved with antibiotics. He was admitted, given intravenous antibiotics, settled down. Neutrophilic leukocytosis, settled down, and that Bhavin also feels has resolved.
Yep.
What I would do in our multidisciplinary meeting is ask the radiologist to come up with alternative unlikely diagnoses because what if
But
what if
Sujit, I
it
strongly
is
still feel that a
so
transbronchial lung biopsy will give a definitive diagnosis
Yeah. So that's what I think
in these
what
patients.
Genome was ready to do, a transbronchial with a EBUS TBNA.
Dr. Ashan, I'm then wondering actually because that in our part of, I mean, Sri Lanka particularly, we see quite a lot of chronic pulmonary aspergillosis. I mean, on top of other illnesses. I mean, this could have been definitely sarcoidosis with ongoing fibrosis, but they see PA, they classically settle in these kind of chronic lungs. Actually, I do
We
believe that it's worth investigating that line as
Sure.
well.
We'll do that. We'll do that, Amila. Only he's not been on steroids at all, so he's not immunocompromised. He's doing quite well. He looks quite well when you look at him, but when he exerts is where the problem is.
Yeah, I mean, CPA that we don't see among the immunocompromised, actually. We see in immunocompetent people as well. Not the invasive aspergillus I'm talking about,
Sure.
especially with the chronic lung diseases. We quite commonly see this association with the post-TB lung and then fibrous lung and associated with CPA. They have a very slowly fibrosing process, and it's very difficult to diagnose most of the time unless that we come with aspergillus specific IgG antibodies and then there's some suspicion. But
Sure,
it's
Amila.
quite common in our population, actually. We see
Point
about 30
taken. Yeah.
35%
We'll
Okay.
do
in
the
post-TB
workup.
lung.
Yeah.
Point well taken. I'll do the workup. Yeah, Murli, you were saying something?
Murli sir.
Yeah, Sujit, I was wondering the first time, did he have things like a Mantoux, a quantiferon TB Gold, where there was
I,
doubt?
I think it was negative as far as I recollect.
Okay.
Because we'd sent the cultures out, everything turned in negative, but because they were random miliary nodules, we didn't want to take a chance, so gave him empirical AKT. The cultures came back negative.
Okay.
I mean,
I
I
think
actually go with what
Have we,
Professor Webb said, get a cardiac MR and then we can plan a biopsy.
Yep.
I was actually debating whether a cryobiopsy would be better or a VATS biopsy. I think it's like a 50-50 thing because you'll get more material with the VATS.
Yeah. Our
Uh,
hospital doesn't have cryo, but there are institutes in Mumbai doing it, and I will just check. Prahlad will know. Is there a high volume center, Prahlad, in Mumbai, or even
no,
a
no.
medium volume center?
No, I think we VAT lung biopsy we generally
No,
prefer.
no, no. For cryo, for
For
cryo.
cryo, I don't think so. We have got high volume.
Okay,
No.
sure, sure. So that's my concern on doing a cryo. We're trying to get more of that done. But I agree with you, Murli, and even Athol said cryo would be the right way to go here. More tissue.
I'm slightly in two minds about that. I mean, if Benarino Paletti was doing the procedure or Claudia,
Yes,
I would go straight to either of those two. The other thing to say, this is the moment you have to do a biopsy because you're not going to watch this very profuse nodular change simply getting worse without it.
sure.
Um, so it has to be now or never to.
And Athol, one last question. If the cardiac MR was highly suggestive of sarcoid, would that preclude a biopsy?
That would tell me that sarcoid was the diagnosis. I would still be inclined to do an EBUS, I
Sure,
think.
sure.
It's a low risk.
No,
Got
sorry,
it.
to butt in, seeing that typical pattern of granulomatous cardiomyopathy in the heart does not rule out TB in India because
Yeah,
we've seen over the last 20 years that TB is actually underdiagnosed in the heart and sarcoid is overdiagnosed because TB can behave exactly like sarcoid. We just got a case yesterday, based in London, UK. I mean, a boy who went for studies had a sudden VTAC, a cardiac MR done, PET CT done, labeled as sarcoid. It's classic sarcoid anywhere in the world. But what they missed in London was classic findings of tree and bud in the lungs that suggest an infectious bronchiolitis, which is your TB in the lungs, which was unfortunately missed. So and we've been seeing this over 20 years. It's been written up by the Hyderabad group, and we have to be cognizant of the fact that even the classic sarcoid patterns
Correct.
in the heart can be due to TB. So you still have to prove it. I mean,
Yep.
which means you still need the biopsy for the lungs to be done. And, this doesn't look like TB at all, though. Having said all this, this now just looks like sarcoid.
I have a plan for him. Thank you so much. Thank you, everyone.
Okay. Manish,
That perfectly explains why I didn't want to make the first comments.
Yeah. Yes, absolutely.
When you refer to London.
I had to bring that in. I mean, it was day before yesterday, James Moon had seen the case and everything is perfect. It's so beautifully done, all good. But the boys come here and now and a biopsy is not being done from the lymph nodes. So now the whole ball is in our court here. So let's see, we'll figure it out.
okay. I think that's it, Fox. Thank you so much. Manish, I want you to make it offline and we will see you again on 5th of April. No, I'm sorry.
Well,
4th.
not me, but yeah, we'll see. Some of you will.
Yeah, 4th of April. 4th of April is the next day. And I think Aparna was there. So
I think the
Aparna will be there.
panel needs to stay online.
Panel needs to stay. And Manish, you can make it offline. Manish, are you listening?
Yes,
Yeah.
ma'am.
Yeah,
We are
yeah.
offline.
Yeah, okay. So I will present the 6th case. I'll share the screen.
So this case is we're discussing this because we took a decision that this ophthalmologist wanted to join online. And Manish, can you confirm we are offline?
Manish, are we offline?
Yes, sir. Yes.
Okay.
Thank you.
Yeah.
Thank you.
Yeah.
Okay.
So this is a 46-year-old ophthalmologist, never smoker, married with an adopted child, hypothyroid, a microprolactinoma in 2015, menopausal for a year, and SLE diagnosed since 2013, Raynaud's since 2020, worse for the last 6 months. So I really need Mithun's inputs here as well. She runs, she does strength training, but she stopped for 4 months. She's at 50% stamina now. She complains of joint pains, terrible joint pains for the last 4 months. Despite celecoxib twice a day, had to cancel her OT list twice. She's also lost some weight in the last 3 months, not a lot, but a little bit. Dry eyes since the past 1 month, and mild dysphagia, but not affecting her functionally. For the last 12 years for her SLE, she's been on prednisolone 5 milligrams a day, HCQS 200 BID, methotrexate as well, 22.5 milligram per week for 2.5 years, and azathioprine between 2020 and 2022. She wasn't tolerating it, so she stopped it. For her Raynaud's, she tried diltiazem, nifedipine, tadalafil. Last year, no relief. Recently, her rheumatologist in Mumbai, Balkrishnan, whom Mithun may be knowing, he started her on MMF for the last 2 weeks, and he's reduced the methotrexate dose to 15 milligrams. And the reason being the lung problem that she has developed, because she's her 50% stamina now, but her joint pains are equally bad. So the methotrexate's come down, MMF is started. ANA and myocyte is blocked. The next slide, Asmita. Yeah, so there's other history that you may want to know, that she had empirical AKT in 2010 for supraclavicular lymph node TB confirmed. She had 2 early miscarriages, never.
Sir,
Multiple
you stop
unsuccessful
your
2 years
video and
for her
present.
microprolactinoma.
Your voice
Can
is
you hear me?
breaking. Yeah, your voice was breaking. So stop your
Sorry,
video.
I have a bad
Yeah.
signal because
Yeah.
I'm in a hotel in Delhi.
Sure.
My video stopped.
That's because you're in
She's
Delhi.
on cabergoline 0.0 milligram twice a week for the microprolactinoma. Yeah, I'm in Delhi. That's the problem.
Mhm.
Her mother had diagnosed at 60, expired at 62. And her husband, of course, she's having a very difficult sarcoma. He's a surgeon, diagnosed in 2016, operated, relapsed, beyond. So that's just to give you a background on that. Yeah. So there's family history, and this is the only lung function we have. 64% vital capacity, DLCO predicted, KCO 80% predicted, and a normal echo.
Yep.
Next slide.
Slide.
Sorry, just give me a minute. I'll just be here. Okay. So, if we can see this, it's a very I'll just start from the bottom. We've got subpleural sparing, traction bronchiectasis, reticular opacities. This is beautiful here, and a little bit of non-dependent upper lobe involvement. So it's a fibrotic NSIP pattern, very characteristic, very consistent with a connective tissue disease ILD. Here's your straight edge, beautifully seen on the right side. That's really it. So, I mean, predominantly fibrotic, very little ground glass. At the most, there may be something here, but that's about it.
So diagnosis CTD related ILD, sir?
Well, it's SLE ILD. She's a known case of
Yeah.
SLE, so consistent with.
Okay.
She's likely having overlap.
This is the pattern, Mithun.
Yeah. The UNRNP, that is the SMRNP, that is the antibody which is actually probably causing the problem with her because she has Raynaud's and ILD. And she also has a Q antibody. It's a overlap, suggestive overlap. SSA also. Okay.
Yes,
So
sorry to
multiple-
interrupt, but I do need to leave. Sujit, is it okay? I've done the CT.
Absolutely, absolutely, Bhavin. I
Perfect.
think,
Thank you.
yeah,
Great.
you've gone
I'll
through
see
the
you
scan.
in
What was your
4
main
weeks.
view on the scan, Bhavin? Anything?
CTD ILD consistent with SLE ILD, fibrotic NSIP pattern.
Yeah. Okay.
Not too much ground glass.
Got it. Thank you.
Thanks.
Sorry for the network. Yeah. Yeah.
And ILD as such is not that common in a pure SLE. Usually
Yeah.
we see with this overlap type of syndromes. And he has a Raynaud's and family history of systemic sclerosis. This is likely Q also suggests of a overlap syndrome. And UNRNP. UNRNP increases the risk of PAH and ILD. This very well correlates with her phenotype, clinical phenotype.
With all these antibodies positive overlap looking, and she's in so much pain, would you also agree with the shift of methotrexate to MMF? I mean, antifibrotics is not difficult to start her on, but I just have one lung function. And should we give her ETRA for her Raynaud's? And what's the prognosis here, basically, Mithun?
Prognosis is not that bad, sir. Usually, it has it is a comparatively good prognosis compared to scleroderma. Usually, overlap syndrome ILDs have a better prognosis, especially SLE. But you have to, if it is a new onset ILD, you need to be a little aggressive. And MMF is the first line depending upon her severity. Very severe cyclophosphamide, definitely cyclophosphamide. If it's a very severe, rapidly progressing ILD, but in this case, I don't think it's a rapidly progressing. It's a mildly Is it, sir? Is it
No.
is her function is
Well,
rapidly worsening?
her symptoms are worse, Mithun, and we only have that one lung function. So I don't know from where she's gone to here. This is the only lung function we had since her stamina dropped, and that's so she was managed by Balkrishnan all this time, and he suggested moving to MMF because of her respiratory symptoms, but her joint pains are terrible. She has had to cancel her OT list twice.
Oh,
So I'm now wondering whether we need a paradigm shift in the DMARD treatment here, or
is he on steroids? 5 milligram, no? He's
5
on 5.
milligrams. That's right. That's right.
Dr. Roshan, I'm wondering rituximab because of
Rituximab,
the
yes.
systemic symptoms plus the fibrotic ILD. Do you think is there any place?
Yes, rituximab plus mycophenolate mofetil. Usually we give combined treatment
Okay.
in this SLE. Most of the study shows it's an add-on therapy like MMF plus rituximab. That is also a good option because rituximab will take care of the joint pain most of the time.
Got it. And with all her other issues, microprolactinoma, all that, there shouldn't be a problem, right, with rituximab?
No, that may not be an issue. And rituximab is a good choice in these type of cases.
Right.
But whether to increase the steroids also for the initial benefit, that also needs to be considered. Actually, her SLE disease activity needs to be reassessed. Like, what is her systemic symptoms? Like C3, C4, we need to do complement levels, we need to do, and the other organ involvement, like any lupus nephritis, like that. We need to see any cytopenias are the
So I'll
those.
discuss that with Balkrishnan for sure.
Okay.
I'll discuss that with him. Actually, he was to join today, but he's down with fever, so he couldn't join himself. But Rituxi with MMF is an option, Mithun. You would
Yes, definitely.
I'll keep that in mind. And cyclophosphamide, if she's rapidly progressing, I just see both her joints and her lungs are
Okay. In that case, rituximab plus MF will be better. Cyclophosphamide may not take care of the arthritis part. In that case, you need to little bit increase the steroids. Otherwise, also you need to. I think we have to increase the steroids a little bit.
Got it.
At least for
Athol, did you want to add something there?
Oh, only to agree on rituximab. I think the EVER-ILD trial is very relevant to this actually. Now, the majority of patients didn't have an established CTD in that trial, although if you had the thing we call IPAF, whatever else you want to call IPAF, but idiopathic NSIP, but with a classic fibrotic NSIP scan and this pathway of ongoing progression, the EVER-ILD trial does provide nice support for that approach. So absolutely nothing more to say.
Super.
Just one other thing, the grounds for going from methotrexate to mycophenolate, really because there was progression in spite of methotrexate. I don't think we believe these days that methotrexate is causing
too late. Yeah, too late in the usage.
Whether it ever does, it causes occasionally this is explosive inflammatory phenotype as a rare side effect.
Yes.
It's been rather debunked as a cause of progressive fibrotic disease, which is...
That's right. If it had happened in the first year of treatment, maybe I would have thought of it, but not.
Probably if it happened that early, yeah. Although you would be a bit skeptical about it, but you probably wouldn't have a choice. But I mean, it was a failing therapy anyway, and I guess you'd have started mycophenolate at the start rather than methotrexate in this setting. So it seemed like a sensible switch.
And the arthritis part, we need to be sure that it's arthritis. Sometimes it can be fibromyalgia-like symptoms. They may think that it is the arthritis causing, where we need not increase anything for the joint part.
Well, she's on celecoxib twice a day and unable to,
but
function.
If it is fibromyalgia, it may not improve at all.
Got it. No, I get it, but she's also very stressed. Husband is unwell. Unwell.
Yeah, I was wondering about that, Sujit. Has enough on her plate, poor thing.
Yeah.
She's going to keep her job going.
Yeah.
Not able to do her job, and we really I mean, she's in a profession which demands a lot of manual dexterity and skill. So the decision on deciding on preserving her joint mobility is very important. So as Dr. Mithun was saying, it's very important to check whether she really has arthritis or not.
Sure.
The other thing that worries me is most OTs are kept very cold. So I don't know whether that's aggravating her Raynaud's.
Yeah.
So that's the other thing that comes to mind.
Right.
I would be very concerned about the discordance between her lung functions and the fact that she's dropped to 50% of her previous ability, a person who was running. So, is there a very significant mood component to it? Does she need that being looked at? I'm not saying it's the only thing. I think we should rule out organic things, but that's another facet that we should probably be addressing.
Yeah.
And but yeah, I would probably try MMF certainly straight away, and yeah, and look for the joint involvements.
Got it. So I think that differentiation between arthralgias and fibromyalgia, I will speak to the rheumatologist about that and tell him I'll keep the EVER-ILD trial in mind and suggest rituximab. And as Mithun said, get the complements and lupus nephritis out of the way. That also needs to.
That probably they may have done. We need to just get the reports. Probably usually Kalakrishnan sir will do those things.
That summarizes it pretty well.
Okay. I think that's it. Then we will be seeing 5th of April. That's our next MDM.
Great.
Bye.
Thank you.
Thank
Bye.
Thank you. Thank you.
Thank you.
Thank you.